Good morning, everyone, and welcome to Minneapolis.
Hello, Professor Sorajja. We can see you well. We can hear you well. It's a great honor and privilege for our meeting to have you and the whole crew. I hope you hear us well.
Very much. You might just turn
Okay.
up my volume a little bit.
I have
I
here.
want to welcome you to Minneapolis. It's a beautiful summer day, 29 Celsius, and temps over 90 degrees. It's very warm. If I could take a moment to introduce the team here, and we have a case that I think will be a wonderful discussion and educational opportunity. To my right is Caitlin Kronenwetter, one of the best PAs on earth. Jay Parikh, a fantastic structural fellow. Right next to me is my esteemed colleague, Dr. Joao Cavalcante, very famous Brazilian imager, who guides me through a lot of things in life. And Dr. Richard Bay, who I can't do anything without, on doing the interruptee. We have Jeff over here on anesthesia, Shelly, a nurse. We have Kayla, Vanessa, and Than back there. And then we have our folks, Hayden and Steve from ABBOTT. So welcome to Minneapolis.
Thank you very much. I have co-moderating me for this case, Mayra Guerrero. Maybe you want to say hello?
Hello. It's an honor for me to be co-moderating this session with my good friends and neighbors. We live 1 hour apart in Minneapolis. So very nice to see you, Paul, Joao, and the rest of the team. Really thrilled to be here and looking forward to see the fantastic case you're going to show us.
Okay, and I have panelists here, and say hello to Joao as well and all the team. Joao, it's great to see you there. So, Paul, we're ready for you. If you want to show the case, please.
Fantastic. If I can have my slides up.
Deve aumentar o áudio, por favor.
Disclosures. Thank you. So this is a 66-year-old woman. She has a history of class 3, pretty severe symptoms. One of the challenges in her, as we're going to discuss this, is she has pretty profound ischemic cardiomyopathy. EF is around 20. It had actually become normal at one point with good medical therapy and revascularization, but has since turned the other way, and she's had to live with this chronic, pretty severe heart failure for some time. She has known multivessel coronary disease. She's had stenting. She's got a CTO of the right that's collateralized. She also has peripheral vascular disease and underwent a right AKA and also a femtip bypass. She's on a good medical program that's been maximized with the assistance of our heart failure colleagues, which we insist for these patients with chronic heart failure. I'm going to show you some baseline images that we're taking as an outpatient. This is just to give you an initial overview. And then when we talk about more about the procedural aspects, I'll have Richard show us some of the current imaging. But one can see here is that the heart's enormously dilated. It's around 6 centimeters. There's no doubt about the severity MR. We can talk about whether this is a mitral FR or a COAP. I actually think it falls a little bit outside of both of those clinical trials. pretty profound LV dysfunction with pretty severe MR. Next slide, please. And then here's just an initial view of the mitral valve pathology. It's pretty obvious that there's a lot of leaflet tethering. We'll talk a little bit more again about the anatomy and about the clipping strategy. The leaflets are a little flat in addition to being tethered, but there's good coaptation reserve at the baseline that would help us put in the clip, and we can talk a little bit more about that coaptation reserve. But the severity MR here is pretty obvious, and it's a pretty broad-based jet. So then I'm going to go to the next slide and turn it over to, one more view, just 3D surgeon's view here, which is very similar to the last slide. Next slide, please. So I'm going to turn it over to Joao, and we have a very comprehensive approach to evaluating these patients. Certainly echo is mandatory, but Joao has really educated me and many others about the benefits of looking at multimodality imaging and helping guiding some of the decision making. So I'll turn it over to Joao if you want to go over these slides here.
Thank you, Paul. It's a pleasure to be together with you here virtually from Minneapolis. And as you see on this patient, she had a cardiac MRI 6 months ago as part of the evaluation when she presented with a small non-STEMI and that profound cardiomyopathy and multivessel disease. On the left top panel, you can see that there's biventricular dysfunction with the left ventricle being severely dilated and severely dysfunction with calculated EF in the presence of severe MR of 22%. The right side is what is keeping things up here. The right side is actually normal in size. It's a mild dysfunction. As you can see on the right, bottom right, she has this calculation of the ventricular remodeling. This is a severely dilated ventricle as well. And the calculated stroke volume of 58 mLs is what should have gone through the aortic valve. But when you look on the top left, top right, I should say, that's the forward flow through the aortic valve, and only 36 mLs is what crosses there. So if you do the math, 58 minus 36, that's mitral regurgitant volume, and dividing that regurgitant volume to the stroke volume is what we call it to be very important functional MR, is a regurgitant fraction. 38% is actually a lot for this poor ventricle. So even though the numbers do not seem to be that alarming, and they're expecting a 50% regurgitant fraction, that's quite a lot, representative of the sickness of the pathology. Next slide. And then that's not only the remodeling that we look into and the amount of regurgitation, but also the amount of scar. So multivessel subendocardial infarct is seen. You can see those yellow arrows there showing both in the RCA, in the LAD as well, with a total scar burden of 15% of the LV mass. Is a ventricle that also not only has this replacement scar from prior nights, but also a ventricle that has been stretched and dilated from the MR that expands the interstitium. This image, colorful image on the bottom right, is what we call ECV. ECV is a measurement of the fibrosis of the collagen. So despite all the medical therapy that we have been able to give to her, she's still battling with that MR, and that's the opportunity that we're trying to rescue her with this strategy. Paul, back to you.
Perfect. Thanks very much, Joao. Next slide, please. So in summary, we have a 66-year-old woman, pretty severe symptomatic MR with the pathology being obviously secondary, and it's related to the ischemic cardiomyopathy, which is long-standing. And as Joao described very well, pretty severe LV dilatation with a scar. She's got coronary disease and peripheral artery disease. She's been revascularized as best as she can. She is an amputee, but she is functional with symptoms that are important to her. And we evaluated it in our meeting, which included surgeons, imagers, and cardiologists. And the conclusion was that she likely would benefit from transcatheter mitral valve repair. And we have prepped a mitral clip device for today's procedure. We'd love to hear questions and comments about the case, and then we can certainly get started here.
Okay, thank you so much, Paul. Really a challenging case. I'll pass here to Mayra first for her comments.
Thank you very much. Well, yeah, it's certainly a very challenging case. Can you walk us through your thought process? Your institution, you do have access to multiple technologies, repair and replacement. What is the heart team discussion when you want to decide repair versus replacement? Is it mostly the anatomy? If it's favorable, then you just go for repair, or what do you normally discuss?
Yeah, I think, one of the issues is, when we talk about repair versus replacement, it's about the risk of residual MR versus the risk of having the prosthesis in place. And in our view, this is a 66-year-old woman. I would certainly love to get rid of all of the MR for somebody who's relatively young. The challenge in her, and I believe this is our conclusion, is that with an EF of anywhere from 15 to 20, to replace this valve, I think it could be quite the burden for her. If the EF were higher and we were shooting for complete amelioration of the MR and the patient could tolerate a prosthesis, then I think we would consider it a little bit more. But I think until we have more clinical data about the benefits of one versus the other, it's really kind of just a consensus approach about the risk of residual MR versus the risk of a prosthesis.
Okay, let's start from the far left here. Cleverson, you want to have some comments and questions to Professor Sorajja?
For sure, it's a challenge case, functional classic with mixed mitral FR and co-opt characteristics. And I would like to ask about if you have experience in some patients like that with 20% of ejection fraction that are going to be scheduled to cardiac transplantation. And if you have some data about this, like bridge, mitral bridge, in putting outside the line to cardiac transplantation after a successful mitral clip.
I love that question because it highlights the multidisciplinary approach that we have and we embrace. When we have these patients with these profound LV dysfunctions, we always insist on a heart failure consultation. And there's always a good discussion about LVAD or transplant. The nice thing about what we do with transcatheter repair is that it does not burn bridges in terms of getting to an LVAD or a transplant. We can certainly treat the mitral clip, and sometimes we'll offset the need for a bridge to another procedure. Other times, the patients, as we know from some of the recent data, can continue to evolve and progress and need additional destination therapy. So our colleagues have been very supportive of it. They've been very supportive of offering what we can do from a minimally invasive approach that does not hurt the patient because it does not interfere with the future options.
Okay. Fernanda?
Hi. First of all, very interesting case. My question for you is, in my point of view, that there is still a lot of viable myocardium. You probably don't have anything else to do about the coronary to recover it. My question is, in your experience in those cases with the mitral repair, if you see some recovery in the left ventricular function, not revascularizing anymore like of the coronary.
Turn it over to Joao. I think, Joao, you could answer that better than I could.
No, it's a puzzle because some of these patients, there is a point of no return given the LV dilation. So the scar, I agree with you, is intermediate, is not a ventricular that's totally burned out, and we revascularize as much as we could, both the LAD and the circumflex. We expect that with the mitral regurgitation reduction over time, with the up titration of the GDMT, because that's the other thing that we see now, is now that we are going to provide better forward flow, cardiac output improves, and then we can up titrate GDMT. The combination of that might improve some of that left ventricular remodeling. The data to date so far that we have seen mostly by echocardiography has been somewhat equivocal, but favorable to say that a lot of these patients will still derive some benefit from left ventricular reverse remodeling. Abolishment of the MR, especially with the TMVR and other devices, seems to provide even more. But it is a patient that falls into that gray zone, and that's the reason we're trying to help.
What I would say is that, a lot of times we have to be careful that we don't overpromise these patients, because I think it's hard to predict the response even when there is viability. I think at the very least, if we can arrest or slow down the progression and the adverse LV remodeling, then we've helped the patient. And sometimes, and I feel this is very important, is that by treating the MR, it allows additional medical therapy. And that's been shown in the trials. And I think if you saw her medical program, there are probably some additional things we could add to that, but she's been really hypotensive and she's at her limit. So treating the MR can often help with GDMT as well.
Okay, so tell us what you want to do, and we're going to be following. We have a few more colleagues who are going to be making comments here, please.
Yes, so I'm going to turn over to Richard, who's going to talk a bit about the anatomy, and then we'll go right into the procedure. So Richard, do you want to go over the intra-op findings there?
So we have some echo images on the table here. You can see the LV is dilated with severe LV dysfunction, tenting on the mitral leaflets. You can see a gap there. This is a commissural view, long axis view. The color, certainly severe MR, very broad jet across the commissure. This is 3D, and we can, off a multiplanar reconstruction, we have plenty of mitral valve area. Posterior leaflet length in the A2P2 zone is about 1.26 centimeters. With color, we get a 3D vena contracta area of about 1 centimeter squared, so very severe MR. We have pulmonary vein reversals. You can see the different pulmonary veins, systolic reversals. And fortunately, only kind of mild to moderate TR. Here, zooming up on the 4-chamber view, we can look at the coaptation depth. We have about 3 millimeters. Paul, Joao, you want to comment on that?
Yeah. So I think this is really important. And so we recently looked at our data on MitraClip, and that when there's a baseline coaptation reserve around 3, that helps predict the MR reduction. And so we can think about trying to lay these leaflets as flat as possible. And one can see here that there's a good amount of posterior leaflet length, well over 10. And so my plan is to go right down the middle with an XCW and to really try to augment this area of coaptation as best we can. And I know that the jet is really broad, but with the amount of tethering here, if we go on one side or the other first, we might pinwheel the valve and make things a little bit worse. I'm not saying we wouldn't end up doing that on this case today, but in this scenario, we're going to try going down the middle first and seeing what kind of effect we get. Do you guys agree with that?
Yeah, that was the question that I was going to ask you about the choice of device. With the wide jet, an XDW, seems to be a good way to start. My question would be, when would you consider an NT? I hear operators that get concerned when there's so much tension, tether of the leaflet, that perhaps the larger size device can result in too much tension, and perhaps the smaller version of the device may be more ergonomic with less tension on the leaflets. What's your thought about that?
It's a great question, Mayra. I mean, it's important for us to remember that the COAP data was built on NT. We did not have XCW in the COAP trial. And so all of those secondary MR patients are treated with NT devices, and we know the results from the trial being very positive. When I would choose an NT versus XT, so this valve, it looks pliable. There isn't a lot of calcification either in the annulus nor in the leaflet. So pulling on this valve, it should be safe, but I hope your prediction is not ominous. So I'm planning on just doing this very gently, and I'll illustrate that. But just to start here, we've already done our transeptal and getting ready for you all. Richard, if you want to show the transeptal, and I'm going to start with the safari wire inside here.
So this was the transeptal. You can see we're very posterior. Height was about 4.3 centimeters. And here on the 3D on FOSS view, looking at the fossa, you can see we're right at that 1 o'clock position. So we're about as high and posterior as we can be on the puncture.
Okay, Felipe, any comments?
Yes, congratulations to the case. It's very interesting. I have a question. Do you aim for a complete resolution of the MR, and do you have any LV unloading strategies standing by?
great question. I do like to have as minimal MR as possible, and certainly we can get an idea as to what the response is to. We just take the guide. Yeah, we can get an idea as to what the response is with the first clip. Usually we have not seen afterload mismatch issues, even in patients who we've treated with EFs as low as 10. And I think that's because, it's an oversimplification to think about afterload as related to this pop-off phenomenon. Afterload is governed by wall tension and the radius of the LV. And if we can reduce the wall tension by reducing the MR, then we just haven't seen those issues as much. We have made the team aware of the potential for a balloon pump need in the event that she gets in trouble when we place this clip, but we have not placed a sheath or anything preemptively.
I just want to make one question about the magnetic resonance image. You did perform this in all the cases that you do for evaluating the mitral regurgitation, and which is the importance of this exam to the pre-evaluation of the patient? Thank you.
Joao, do you want to comment on that?
I actually, the question was not so clear to me. Could you please repeat one more time?
The importance of magnetic resonance image of the pre-evaluation of the patients with mitral regurgitation. You do this type of image in all of the case?
Yeah, so thank you. The CMR, the cardiac magnetic resonance, has been something that we have been using much more upstream for the management of these patients, and trying to really expand beyond the understanding of what has been proposed as disproportionate. I think there's an important third component that is not factored in, which is the amount of scar, in addition to the remodeling and in addition to the amount of MR. So we do this. We take patients, even if they have intracardiac devices, ICDs, defibrillators, or CRT devices, and we have a very steady program to try to image these patients as much as possible to better understand what is that ventricular reserve, if you will.
It's a good question for you, Joao. It's like, the MRI is not available everywhere. I mean, what do you think in terms of availability?
Yeah, so MRI is not available everywhere, and there is a growing program. I mean, we're trying to do this education through here in the United States, the SCMR, and also in Brazil with other colleagues coming up with the imaging meeting in a couple of weeks in Brasilia. We're going to bring some of those insights. I think, MRIs are done everywhere for the brain, for the back. For the heart, is obviously a bit more complicated because you have to synchronize. But it is possible. An alternative to that would be obviously to try to understand ventricular remodeling, maybe some scar, with the use of echo strain, which is a surrogate of that. You could try to do that. But also ventricular volumes by 3D echo or by cardiac CT.
STW?
So all of these pieces, these patients, you need to understand that better. And sometimes the answer is quite straightforward when you have a transthoracic echo. But in patients such as this one, there is a dilemma between, what is the recovery that we should expect, provided that we achieve great procedural results, is something that we bring it in, all the armamentarium to inform the decision.
So, Joao, any specific protocol for the follow-up of these patients in terms of imaging?
So it's a typical sequences that we use are the cine images, the breath hold, that we see the whole cardiac cycle, and we acquire that. We do also the phase contrast, which is the typical flow quantification. We need to measure both at the aorta and the pulmonary artery. And then we inject the gadolinium. And the gadolinium piece here is important because it's going to be assessed in the myocardial scar. Then we do the late gadolinium enhancement. In Brazil, we call realce tardio, in which we take a look, and this is a sequence that is available everywhere, and that's already has been very well established for the last 15 to 20 years. The other colorful map that I showed to you is not something that is available everywhere, but that is something I believe that is going to become even more important. Two is the interstitial fibrosis, is the collagen, not just the replacement scar, but the reactive scar that we hope by fixing the MR might be somewhat plastic and reversible. So those sequences are now gathering more momentum. The CMR community is spreading that. But the sequences for function, flow, and SCAR should be done pretty much in every single MR center that does cardiac MRI.
Ricardo, one quick comment here.
Sure.
Is that in Brazil, in our reality, most of the centers are in a learning curve with mitral clip. It's not the reality for most of centers in Latin America and Brazil. And it's interesting because in the learning curve, we search to fix sometimes the jet. And we are looking to a case, a classical functional case with a large jet, but the experienced team from Dr. Poe and other guys, they are trying to fix the anatomy defects of the valve. And that's, I think, is a great point of this case.
Any comments, Mayra?
Can we get tight of arms 200, please?
I'm not sure that if I understood the
Thank
comment
you.
about fixing the anatomy. Can you repeat that, please?
Yeah,
See,
Mayra
we've,
just comment about
inserted
what.
and steer down.
Yeah.
Sorry.
Okay, so
I'm sorry, go ahead, Ricardo,
you're in
sorry.
position there. So tell us what the next steps now, Paul.
Yes, so we've steered down. I don't know if anyone had noticed, but left atrium, despite her chronic heart failure, there wasn't a whole lot of room posteriorly. So we had to clock the guide anterior and add a little plus to it actually to make sure we were safe. I've centered myself above A2, P2, and then our anesthesia colleagues have turned the tidal volumes down to 200. Usually 150 to 200 to reduce respiratory motion. And then you can see here that Richard has already lined us up with MPR, which I think has just been absolutely game-changing. This helps us be really perpendicular to that coaptation plane and really allows us to monitor the trajectory as well as the clip arm orientation during the entire procedure. Previously, if one remembers how mitral clip used to be, we used to have to go into the stomach to look at arm orientation. We used to have to do 3D and then X-plane, switching between the different views multiply. But this MPR really has been quite game-changing in that we can get all the views simultaneously. So one can see here that I'm probably a little bit medial. You agree, Richard? Yep. We're going to push over just a little bit when you get down the middle. And then I'm going to just check the button for the gripper. So the gripper is anterior for the button. And then I actually think the trajectory is actually pretty good. And I think, the nice thing is that, with this setup, with this MPR, you can see here that we have really good alignment. And it was all started with a good transeptal too. So how do you guys like this? Do you like this starting? I probably could go just a bit more lateral. You agree, Richard?
Yes.
Yeah, and that happens when we drop the tidal volumes. We tend to drift a little bit medial.
I was thinking
there you
that
go.
Paul, I was thinking that medial, slightly medial position would not be bad actually. If you end up requiring or
Yeah.
needing a second device, then you'll just go medial to lateral. But either way, those are good,
Yeah,
good positions.
I completely agree, Mayra, because I think, it's definitely easy to go medial to lateral. I'm hoping that we get pretty good MR reduction by laying everything flat by going down the middle. But I would anticipate, and this is what we know from the trials too, that usually we put in 2 devices for these. But that was also, again, just a gentle reminder, that was with NT. And so with XT or XCW, how many devices we're using, not entirely sure. How do you guys like the orientation? Do you like it?
Fernanda?
It seems good. 12 o'clock, right?
Yeah, okay.
Yeah, it looks good.
10 minutes left. I just want to do a time check. Okay. 10 minutes. All right. So we'll just go in here. So, we're just going to go in super slowly. And we can see here, Richard's got the red plane and green planes matched up for me. And then we're just watching this trajectory. I'm closing the arms as I go in. Drifting just a touch anterior, so just a little clock on
Do
the
you
guide.
always close the arms completely?
I like it because when the arms are really big, I don't like the leaflets pushing me around. And also, this is a way of protecting the friction elements or the grippers. Historically, we used to go in with the arms open, but the issue with that is that the grippers can pick the leaflets on the way in, and with that, they may not lay as flat as one wants to. So it looks, I think we rotated, Richard. You agree?
Yes.
So I'm going to come up just a little bit.
One thing
Just
that
open the arms here.
could help is sometimes is to put the arms aligned in the fluoroscopy, and you look to the arms when you go into the ventricle in order to see if there's some rotation in the clip.
That's exactly right. So I didn't show you on fluoro a moment ago, but we do like documenting that on fluoro and then kind of matching the things as we go in. Okay, so I think that's better. So we had a little rotation as we were going in. So now I'm going to close arms again. Again, that's another reason I like going with the arms closed. We drift just a little bit medial. You agree, Richard?
Slightly.
Okay, so we're going to come up here. There we are. Just a touch medial, but maybe that's where we need to be. Okay, so now what we're going to do is just open super slowly. Just going to check the arm orientation. I actually think it's too medial, guys. I'm going to come up. Taking the M off here, Richard. All right, that looks a little better. And actually, you can see the arms a little bit better too in the red plane. See that? Okay. All right, so we're going to go just beneath the leaflets. Did we drift medial again there?
Minimally.
Minimally?
Millimeters.
Okay. All right, let's see here. Okay, arm orientation looks good. So I open the arms super slow. So here, if there's an issue with arm orientation, I can adjust now. But I like this orientation so far. I'm going to give it a little counterclock. And then open a little bit more. Pull up a little bit more, open a little bit more. Now we're at 120.
You guys, you don't actually step on fluoro because for us it's frozen, the fluoro image.
Oh. Yeah, it's frozen, but here, if you want to look, there you go. That's what it looks like. Okay. So here you can see on MPR, the location looks pretty good. And I'm going to close to 120 just a little bit. And then, Richard, shall we look on 2D? Mm-hmm. So certainly there are different schools of thought about doing this entirely on 3D versus 2D. And I know there are centers around the country that like even dropping the grippers on 3D. My personal preference is I really like 2D. And the reason is that sometimes on 3D, it can be easy to miss the leaf folding or curling. And so this is this is a nice potential example. You can see there that Richard is highlighting that posterior leaflet, and see how that would have the potential to fold, which is really hard to see on a 3D image. And here, the anterior leaflet is really well inserted, but the posterior leaflet, if I didn't have that quite right, it would not lay flat in the arms. And so I actually think if I just pull up a little bit, it should go right into the armpit of the posterior arm. So I'm just going to pull back a little bit here. Richard's keeping that view. That's quite nice, Richard. I'm going a little posterior in the guide. Mayra, what do you think?
Looks great.
It looks good, and I agree with you that switching to 2D is very helpful, so it's worth spending the time to improve the visibility.
Yeah. Okay. So here we'll do a gripper drop in this view. And there's beautiful bounce on that gripper. Okay, and this is also where we go super slowly. And to Mayra's point about NT versus XT, this is a bigger device. You want to go really gentle. And so I'm going super slowly. Insertion is staying.
Do you check
Locking
left atrial
device
pressure
here.
as you do that? Do you have a left atrial waveform?
Yeah, it's a good question. So
I like to
we
see-
do have, yeah, do you have hemos? Yeah, we do have hemos. So, but I'll tell you it's a little damp because we've got a lot of extra curves in the catheter right now. So I'm not sure how reliable that is. But I like the location. Richard, you like the location?
Yes, it looks good.
Right down the middle. Okay, so let's see what happens. So you have it a nice view. So I'm just going to go super slowly. And look at the MR, guys. Here we're closing. And we're fully closed. And now I'm just going to go back to neutral. So this is a beautiful result.
Yeah, more than beautiful. I think if we had hemodynamics that were more reliable, you would have seen an improvement, hopefully, in the left atrial pressure. The other change that we often see is the systemic blood pressure. The aortic pressure may increase at this point. And I think having those two parameters in the hemodynamics results, then
Changing-
it's more encouraging
changing
that
the aortic pressure.
the patient will feel better.
Did it go up? How much did it go up by? Okay, so Mayra, to your point, the mean arterial pressure went up 12 points when I closed.
Wow.
There you have it. Beautiful comments. Yeah. So I
This
think
is just
a
this
really
is just
nice
fantastic,
example,
very elegantly
of-
demonstrated. Yeah.
Thank you. Again, historically, mitral clip was, considered an alveoli stitch, and I've been on the podiums trying to trumpet, that we have to think about it differently. We can't just think about tying the leaflets together. And people heard me say this publicly. TEAR is the worst acronym for this therapy. It's not edge to edge. It's a coaptation restoration device. And when we think about trying to get the leaflets to lay flat as much as possible, then we get the results like this. And it's one device and such. Richard, do you want to show a tissue bridge and gradient? Make sure that we're all safe here. And I actually think we're in the last 3 minutes, so this is perfect. Three. Mean gradient's 3. MR results good. So we would agree with releasing this. Agree, Joao? You like it?
Great, beautiful.
Yeah. Mayra, Ricardo, any questions about releasing this device or from the panel?
So, Mayra, it looks like as good as it can get, right? In a challenging situation like this.
It is just perfect. So really, really congratulations. The gradient, it's not high. I mean, 3 is good. I don't know what else
3.
could go better. It's as good as it can get. Completely agree.
Yeah, it looks like a very good result. You got a lot of leaflet, and the leaflet is very healthy, so you can feel very comfortable to live just with one device. It's a perfect result. Congratulations.
So you want to go ahead and release?
Yes, we will release it. And then I think they're waiting for you for the other case, right?
Yeah, I think we can have 5 more minutes here for you to finish the case
Okay.
or release, and then we can move to the other room.
So we're just saying FAA, so that's the first test. Let me just test that one more time. Good.
A question while you release, and what is your approach to the iatrogenic ASD that is created? Do you leave it alone and let it work as a pop-up valve, to decompress the left atrial pressure?
Yeah, I think it's a great question, Mayra, especially with all the new shunt trials that have come out. A lot of those devices create 7 or 8 millimeter defects, which happens to be 24 French. That's great, thank you. And 24 French is kind of what we're leaving behind. So if there's no injury to the atrial septum, if there's no bidirectional shunting, then we will leave it. And I think a nice little pop-off is probably a good thing for these patients. All right,
Congratulations.
so, okay, I'm off to you.
Hélio, please.
It's nice, huh? You guys like that? I'm going to give you LA pressure here in about 2 minutes. Less than that.
Okay, we have a simple question. This patient, how long this patient stay in the hospital, and you send him to the intensive care or not, and if you use perclosing the femoral vein?
Excellent question. So it's typically overnight stay. In the U.S., we have a 2 midnight rule and for inpatients, but this is kind of like an outpatient situation. And it's overnight stay. They'll go to the telebed, usual telemetry, and then we'll close this with the figure of 8 stitch. Can you all see the hemodynamics? Oh, wow. So in the beginning, I'll tell you, when we induced her, she actually became quite hypotensive, needed some pressors, epi, vaso, and we did the transeptal and we figured out why, because the LA pressure was over 30. And so, and the V wave was 53. I don't know if it's possible, Vanessa, will you be able to scroll back and show that tracing in the beginning? And then you can see now how the LA pressures come down acutely. Here the LA is, let's see here, 22, and from baseline of 30. Yeah, see, this is what it looked like in the beginning.
Oh my gosh.
So this is why she got in trouble with the anesthesia induction. But they did a great job getting her stabilized. And then one can see her with treatment of her MR, her LA pressure. Thank you, Vanessa. It's already come down acutely. And again, I think this will allow more diuresis, more medical therapy for her. I'm going to pull the sheet back into the right atrium, and Richard will do a septal check here, Mayra. Your question, one can see there. It's all left to right. We did go through a little bit of the thick part of the septum, which I would encourage people not to be afraid to do if one needs to, especially if you have a Baylis or an RF system. If it's thick and you don't, I'm a little more hesitant, but here we have Baylis and went straight through and it's all left to right. So we will leave this, and that could help her as well.
So, Paul, this is just fantastic. We couldn't have started better. Very elegantly demonstrated, and you're so calm and step by step, so didactic. We have learned a lot here. We have a full room in our main arena, so I think we should also give you the congratulations for you and your team before we move to the other room.
Thank you. It's a real honor on behalf of the entire Minneapolis team. It's been amazing to share this experience with you, and I'm glad it worked out really well. Obrigado.
Thank you so much.
Well done.
Okay.
Obrigado, um abraço.
Thank you.
Tchau.